Thanks. I'm enormously honored to have the opportunity to participate in today's conversation. As we heard in the morning session and from the earlier presenters on this panel, the current care delivery system too often imposes considerable demands on individuals living with serious illness and their families, leading to tremendous financial, emotional, and physical consequences and burdens. We've heard about some of the problems and the consequences of the current care delivery paradigm. And in my remarks, I would like to turn to the how we as a community and as a society can make a difference in moving the needle in research, policy, and practice, leading to a more supportive care delivery paradigm in the future. And I have three main points I'd like to make in my remarks. The first is that I want to acknowledge that individual clinicians and healthcare professionals are typically enormously committed to meeting the needs of individuals with serious illness and their families, but that the traditional and entrenched care delivery paradigm is not well aligned with the delivery of person-centered care and is particularly misaligned with the delivery of family-centered care. For example, coverage decisions for reimbursable services are typically predicated on an individual's health, insurance coverage and do not compensate clinicians and other health professionals for the additional time that's necessary to educate, counsel, and support family caregivers. The prevailing bioethical and legal regulatory frameworks appropriately prioritize individual privacy and the protection of personal health information, but often lead to challenges for family members who are tasked with coordinating care, managing care, and overseeing care of individuals with serious illness who lack the capacity to manage care themselves. Clinical assessments often ask about the availability of help to bridge functional deficits and cognitive impairment for individuals who require help to enact their care plan. But these assessments typically don't involve direct interactions with family caregivers, and as a consequence, too often the information is of questionable veracity, and family involvement and ability to participate is simply assumed. A challenge is that because families fall outside formal regulatory, legal, and financial arrangements, they're largely invisible in care delivery, as we've heard earlier today. And this leads to missed opportunities in terms of understanding how we may go about better identifying and supporting families and individuals with serious illness, in particular those who are at risk. Currently, we don't even know who is most at risk and how we can go about better supporting them. The second point that I want to make is that effective interventions for families of individuals living with serious illness exist, that we're not operating in a vacuum of evidence. We heard from Dr. Schultz that the effects and circumstances of family caregivers are highly variable. Because of this, it's not surprising that interventions that are most effective are comprehensive, multi-component, and tailored to the individual circumstances of caregiving and the serious illnesses that are being managed. And because of this, caregiver assessment, which Lynn Feinberg describes as having a conversation with a purpose and really understanding from the caregiver's perspective the specific challenges, needs, strengths, and preferences of caregivers is typically foundational to effective interventions that have been proven to work. However, it's notable that despite a large, robust body of evidence that has been developed through rigorously conducted randomized trials exists, that there are enormous gaps, in particular with respect to the generalizability and the diversity of populations that have been studied, and importantly, with respect to the dissemination of these models into care delivery. And as a consequence, very few caregivers now benefit from the body of evidence that's been developed. So overall, what we can conclude from the available evidence in this area is that it's very important at this point in time to think about how to go about doing research in new ways, in particular leveraging implementation science and moving towards developing pragmatic embedded trials in care delivery that focus on engaging key stakeholders at the outset, the stakeholders who would be responsible for diffusing these models. And I would say that NIH has really is been moving forward in this area with funding announcements really oriented towards this kinds of research. This is the framework that served as the basis of conceptualizing interventions to better support family caregivers in the Families Caring for an Aging America report. One of the major takeaways of the report was that most of the interventions that have been developed to date have been undertaken at the individual level, focusing on individual interpersonal processes within families, with far fewer focusing on the outermost segments of the framework, focusing on the organizational level systems such as in care delivery and societal level interventions. And I was really struck by the comments earlier this morning by the discussion about the importance of the educational system in really allowing the Spittel family to benefit from education about the conditions that they were managing. And I would say that those types of societal level interventions are far fewer in terms of thinking about individuals who are living with serious illness at older ages. And there's even less attention to thinking about interventions that span the organizational and societal level in terms of bridging healthcare and social services. So the third point that I want to make is that there are a number of encouraging shifts in payment and delivery reform that are now underway that are promising in terms of thinking about how progress may unfold in the months and years to come. In particular, as we heard earlier, with respect to the direct care workforce, there are a number of promising activities at the state level in terms of paid family leave, as well as model legislation that's been developed by AARP around the CARE Act to better support family caregivers at the time of hospital discharge. And then critically important, there's a growing awareness at the state level of the importance of thinking about models that bridge healthcare and social services, for example, in Washington State, in terms of bringing together the administration of community living supported programs, the National Family Caregiver Support Programs with Medicaid. On the federal side, there are a number of promising activities, in particular with respect to new billing codes by Medicare that allow clinician reimbursement for non-face-to-face interactions with patients and families, in terms of new conditions of participation that set forth an expectation that providers will educate and counsel family caregivers, for example, in home health in the hospital discharge process, in terms of Medicaid, sort of moving towards an expectation that caregiver assessment will occur when the care plan requires the involvement of a family caregiver. And very importantly, in terms of promising efforts that would realign processes more broadly, are bundled payments, which allow providers the flexibility to innovate in new approaches to better support individuals as well as their family caregivers. And I think the main point that I want to make across all of these is that these developments are, for the most part, providing the opportunity for care delivery to engage families rather than a mandate, and which we might hope would be sort of moving in the future in terms of thinking about systematic strategies that would make possible engagement of families more broadly. Lynn Feinberg recognized the passage recently of the Raise Family Caregiver Act, which sets forth an expectation that the Secretary of Health and Human Services will develop a national plan with multiple private and public stakeholders to move forward with strategies to better support family caregivers, including monitoring the experience of family caregivers and progress towards achieving that goal. And so in my final remarks, I'd like to talk about some of the key elements of what a national strategy might look like. In the Families Caring for an Aging America report, we note in more detail what some of these elements might look like in terms of of identifying family caregivers, moving them so they're not part of an invisible workforce, but they're more readily identified. And there are a number of strategies I've listed. For time's sake, I won't read them all, but there's suffice it to say there's likely not one single approach, but multiple approaches. In terms of engaging family caregivers and incorporating their perspectives and insight in care processes, for example, in experiences of care. In terms of interprofessional care, in clarifying and legitimizing the family caregiver's role, assessing and respecting capacity, and providing tailored supports to better support families. And then finally, moving towards a coherent strategy, importantly in terms of developing capacity to monitor the experience of family caregivers and our progress towards achieving a more family-centered care delivery system that is deliberative and that is integrated across care delivery systems. So it's not just within healthcare, it's healthcare and bridging healthcare and long-term services and supports, and so that we can monitor the effects of our progress in the future. And I will end there, and I'm looking forward to the discussion. Thank you.